welcome everyone to the NOAHE, Network of Alberta Health Economists lunchtime series, which we're pleased to host the Institute of Health Economics, Alberta Health, the University of Alberta, and the University of Calgary. And this is a second invitational luncheon series. We held it last year, and this is the second installment of it, and it provides a ability to have some key researchers and thought leaders in the province be able to present to Alberta Health and other guests around particular key health economic concepts and topics which are of interest to you in your applied work. First of all, just a housekeeping thing, we'll be having a presentation for about half an hour, 35 minutes, and then, sorry to those who are online listening, but we'll be actually signing off from that particular presentation. We'll be having a question and answer period with those who are participating in the room. But I'm John Sproul, by the way. I'm Senior Policy Director with the Institute of Health Economics. We're very pleased to have as this first installment in this next series a discussion of waste in the healthcare system, and we have someone who actually has a lot of experience in the particular area. Dr. Fiona Clement is from the University of Calgary, and she heads up as director of the Health Technology Assessment Unit at the Bryan Institute for Public Health at the University of Calgary. And Fiona comes with a lot of experience over the last number of years addressing and looking at this issue. And there aren't a lot of people in Canada looking at this systematically, and she's partnered not only with individuals across the country, but also people internationally in looking at how one might systematically address and look at this issue. Fiona, we're pleased to have her in Alberta, and as a partner with all of us. She was recently in 2014, she was recognized internationally and served as a Harkness Scholar, which is a kind of an annual club of people, or 12 people are selected internationally to participate in a focused training program in the United States. It's like a Rhodes Scholar or Fulbright Scholar kind of thing, and she's actually took time off from her academic work and had the horrible time to have to go down and live in San Francisco for a year, and was able to return with those particular kind of learnings. And also, I believe it was in 2015 that she was given the Morris McGregor Award from CADIT, the Canadian Agency for Drugs and Technology and Health, for outstanding leadership and excellence in health technology assessment in Canada. She is an emerging and as well as established kind of leader in the country, and we're happy to have her in Alberta and happy to have Fiona give the first presentation in this series. So we'll have a presentation from Fiona, and after that we'll be having questions. But over to Fiona. Dr. Clement.
Thank you for that kind introduction, John. It always makes me blush a little bit because Calgary is home for me, and so it's my privilege really to serve Alberta and work towards a more sustainable healthcare system here in the province. So as John said, I'm going to be speaking to you about waste in the healthcare system and really moving beyond just kind of the words which we've been chattering about for, since 1988, so close to 3 decades now. Really moving towards action. So I'm going to start by kind of talking a little bit about how we might classify this and putting some boundaries around what I will speak about today, because I'm not going to speak about waste in the system writ broad. And then I'll talk a little bit about what's happening internationally, some of the challenges that have already been documented, and then work that's ongoing here in the province and what I think the next steps are. So first, just a note about words. Waste is very colloquial. I think it's easily understood by many people but as academics do, we like to fuss about our words. And one of the things that waste invokes is a very pejorative kind of knee-jerk reaction from people within the system who say, what I do is important. I'm not wasteful. I think about resources. And so even though waste is perhaps really easily understood, some of the other labels that you might see that in my experience, invoke a little bit less of that knee-jerk reaction is kind of the concept of unnecessary care or unnecessary processes, low-value care, low-value processes. You might see the word inappropriate or possibly inefficient. And in our academic world, each of these has a slightly different, subtle, nuanced, different meaning. But I believe that on the whole, most of the definition overlaps. So throughout this, I will be using language of low value, not waste. Out of Ontario, there's been some work done to try and classify waste that you might see in a public single-funded system. So this builds upon a classification scheme that came out of the States, where really they were talking about waste in a multi-system, multi-payer, multi-provider system. So here you can see that they've categorized it into 3 different buckets: administrative, operational, and clinical. And then within each of those buckets, they've kind of got layers. And I would suspect for many of you in the room, you could probably think about examples for each of these buckets, or if you sit in one of those buckets, I'm sure you could think about 10 things that you think might be wasteful spending or low value. To quantify this, and we don't have good numbers in Canada, but estimates are that there about 30% of healthcare spending in Canada is unnecessary, inappropriate, or of low value. And these are numbers out of the US, and so reduce them by about 10 times, and they might approximate what you would see in Canada. But really my point with this slide is those are very big numbers. And so certainly if we were to target value spending or inappropriate spending, we could achieve a reduction or reduce the growth in our budget. And by its very nature, because we've identified it as low value spending, we would not expect to see an impact on the quality of care, the quality of the system, or the outcomes that our healthcare system achieves. For my presentation and for my own expertise, I really focus on this clinical box, although I do have a little bit of expertise and some knowledge about the duplication of services underneath the operational branch as well. So really what I will be talking about here is efforts that are aimed at changing the way clinical practice is done within the system, whether that means at the level of a doctor and a patient making an individual decision, so I will do this test, I will not do that test, or whether it means more broadly saying we will not pay for this within our system, we will pay for this instead within our system, we won't pay for a doctor to do that, we will have that task done by a nurse. All of those kinds of things are the types of things that I'll be talking about in this presentation. Also want to flag for you that when we're talking about waste, we're not just talking about tests that are overutilized or utilized in a population that maybe doesn't drive benefit. We're also talking about effective interventions that are not maximally utilized. So maybe statins is a good example where we know they work very well to lower cholesterol in a group of patients. About 60% of patients who should be on those are on them. So that's also an opportunity for waste to be within the system. Okay. According to what's happening in the world, we're all at about the same stage, so that's kind of an exciting place, and particularly for a young researcher, to have this emerging group of people who are all looking at the same thing and who are learning together is a really exciting research agenda. So it's been a lot of fun, and as John said, there's been a small group of us internationally that have emerged, and we're having a lot of fun looking at this and hopefully making an impact. So there are definitely initiatives across the globe, although in very selected areas. And usually the rationale for why systems adopt these kinds of things are because they're interested in cost savings. Usually this is framed in the context of a limited budget or growth that is being reduced. And also they want to ensure patient safety and quality of care. So you'll notice here that you're not seeing words of like rationing or taking away care that we know is to be effective. This really is about system sustainability and grounded in the idea that our costs are growing too fast with outcomes that are not improving at the rate we would expect them to given the increase of investment we're seeing. And there are a variety of different approaches and frameworks being tried, so that's also very cool to see. When we look internationally, this is just a map. Each of the dots represents an area where we've seen some activity in this space. So you can see there's quite a few, but it's heavily concentrated where you might expect it to be. So in the more developed healthcare systems, generally the OECD kind of nations. And then the green dots are where you've seen actual action happening. So beyond think pieces or strategies or recommendations, we're actually seeing some kind of action. Again, there's only 3 of them on there, and it's what you might see as the usual players, so Canada, the UK, and Australia. What are we trying generally? These are the approaches that you're kind of seeing emerge. So there's kind of 4 buckets that we were able to find in the literature. HTA Plus being your traditional health technology assessment with the added focus on implementation. So just historically, health technology assessment has really stopped at the evidence synthesis piece, helping the system understand what should you do. Should you adopt this? Should you not adopt this? Should we design it this way? Should we design it that way? Without actually offering any support of, okay, how would we do that? What might work here? What kinds of tools do we need to use? Who do we have to engage? So the HTA Plus is still grounded in that HTA roots of evidence synthesis, but really pushing further into the implementation. Program budgeting and marginal analysis has actually been tried out here in the province about 2 decades ago, down in the old Chinook region. And this is the idea that you would look at everything that you're offering, you would assess what it's giving you in terms of outcomes that you've agreed to and the cost for it. And then if a different program offers outcomes that you value more, you would reallocate the budget at the margins to achieve, to maximize the value that you were getting out of your budget. So we've seen that kind of tried out a little bit. And the last thing we're seeing, and this is really the most popular of them all, the list making. So here we're categorizing things like choosing wisely Canada, choosing wisely American version, choosing wisely the Australian version. There's a do not do list out of NICE, which is in the UK. And these are just generally lists. And here in Canada, under the Choosing Wisely banner as an example, these lists are developed by the professional medical organizations. And they're put out there broadly for doctors to check out, to say, you know, here are 5 things within our clinical practice that we really think you should think twice about doing. Engage in a conversation with your patient about it before you just kind of do this as a matter of course. So things on that list might be, for example, imaging for low back pain, where in very selected groups, it's meaningful and it might change your clinical course. In a lot of patients that undergo imaging for low back pain, it is not a helpful test. So really kind of thinking twice about the patients you're asking for that test and discussing it further with your patient about whether it's right for them. So as you can see from those 3 approaches, they are kind of very academic, I would say, in their nature. The list making is perhaps the most practical approach, but still really falls short, in my opinion, as it's a list that's put out there that people can choose to read, choose to act upon. There's really no implementation plan or bite or adoption requirements behind it. So generally, I think we're seeing very slow movement forward here. Of course, there's lots and lots of challenges with this space. I'm sure many of you have already thought about most of them in your heads. But there has been some documented work done that I think really highlights and describes what we would all anecdotally expect anyways. So when we talk to healthcare system administrators and managers, there's kind of 4 things that they identify as hurdles for them to actually move from identification of low waste or conceptualization of low value care to actioning something in the system. So the 4 there on the slide with limited guidance, lack of time and resources, difficulty engaging stakeholders, and that's, I think, particularly true the further removed you get from the front line in the clinical care. And in some cases, a lack of political leadership. This could lead to some very tough, politically unpalatable choices. And if you don't have that leadership and that will at the level that you need it, it would be a big hurdle to moving forward. When we speak about healthcare providers, from their perspective, they comment on really uncertainty in the definition of the goals. They really don't understand what we're trying to do. And particularly for those that might be further away from their training, you know, remember that talking about costs and trying to manage costs as a scarce resource in healthcare is a relatively new concept. Like, we really didn't start talking about that within our practicing clinician community till like the late 1990s in a big way here. So depending on that, they might not even understand like what you're trying to do here. And again, going back to that terminology of waste, particularly for an individual provider, I do believe that they are always making the best decision for the patient in front of them, or that's what they're trying to do. So the idea that there would be a problem with that is a bit foreign to them. They do view this as a very top-down approach, so especially when there's a lack of engagement, they feel that this is kind of being pushed down from the upper echelons of either government or the healthcare system or their operational leaders. And there is priority fatigue. And I will flag for you that this is not Alberta-specific data. So that priority fatigue you see coming up repeatedly internationally in any papers that report this kind of thing, where they're just tired of constantly having to address a new issue. And then from a patient perspective, you hear some of the same kinds of things that I've already touched upon with the other two stakeholder groups. There's a difficulty understanding what we're talking about when we're talking about low-value care, or conceptualizing the idea that perhaps what is happening in my care is not right, or it's not high value, that there are things, there's a real struggle to conceptualize what we're talking about here for them. And then the other thing from a patient perspective that is commented on is that cost considerations in the individual patient-doctor encounter is tough to swallow and generally viewed as unfavorable. So what do I see as common threads across those three different stakeholders? So generally all of them comment on capacity. You saw that kind of repeated. There's a lack of understanding on the definitions, the goals, why are we doing this, why does it matter? Incentives are important. So you're asking me to do something differently when I've already got a routine and kind of a vibe going on about how I do something. Now you're asking me to do something differently, like that's kind of tough for me. And then engagement. And we see that consistently across all three of those stakeholder groups. So jumping into the Alberta journey so far, and this is only kind of the part of the journey that I've been involved in. So I'm sure there are other pieces moving here. So please, when we're in the conversation period later, please feel free to jump in with how this resonates with work that you may already have going on in your area or other work that you're aware of, because again, this is just from my little corner of the world. So if I put it to you on a timeline, in about 2008, there was initial provincial conversations around what we call health technology reassessment. So the idea that we want a process to actively manage the low value care that we're seeing emerge. And at this time, it was focused mostly around like very traditional definitions of technologies. So fancy devices that would be, had either the evidence had shifted and we knew that they weren't providing the value that we wanted, or there's an alternative that's coming out onto the market. And so how are we going to manage what's currently happening, recognizing that we can do better now? It has since kind of really morphed to be much broader than that traditional device definition and to encompass processes of care, operational procedures, still some devices, drugs, but much, much broader definition now. When 2012 came around, when the strategic clinical networks were initially launched, they were launched with a very specific mandate to complete one health technology assessment, reassessment, within their scope of projects. After that mandate came out, for those of you that are more long in the tooth, you'll remember there was a major shakeup with some CEOs and some executives being fired. There was a changeover in the ministry, and the SDN mandate got changed very quickly to kind of back away from that HTR mandate. Sometime between there and 2017, there were also committees struck both within Alberta Health Services and then joint committees with the AMA, Alberta Health, and Alberta Health Services, who were interested in looking at appropriateness, as they've called it, evidence-based clinical care, and identifying opportunities for savings and bending the cost curve. And then in 2017, very excitingly, we started to pilot the HTR approach. So there's a lot of background work happening within all these time periods. And just to really highlight for you, really I think what has kind of moved this forward to where we are now, and for some they might look at this and think that's a really long journey. But there are lots of reasons why it's taken as long as it has to get to where we are now. And I would like to highlight that particularly from 2012 to 2017, the openness to collaboration and the willingness to work together has noticeably shifted, and that's been a huge facilitator to moving this forward. So what did we propose? So throughout my academic work, looking at what everyone else was doing and kind of coming up with what we thought might work here in the province, we came up with a 3-step, 6-phased model that we put forward for how we could conceptualize reassessment. We took this forward and it was kind of endorsed as the model that Alberta would like to move forward with. So you'll see you start with figuring out what you want to look at, like what do you think your target here is, your technology. Then supporting an evidence-based decision, so that's an evidence synthesis usually, and a decision about what the policy might look like. And then policy action. And importantly, in that last phase, we have 2 steps of kind of monitoring and evaluation as well as implementation. So the actual doing, the changing of this in the system, and then monitoring it to make sure that it, 1, achieved what we wanted to achieve, and 2, looking broadly for unintended consequences, making sure that we didn't accidentally cause a ripple effect that is creating a big problem somewhere else in the system. You'll notice running alongside all of this is meaningful stakeholder engagement, authentic stakeholder engagement, as well as ongoing knowledge and exchange. And these really are the foundations of this model. Without those 2 pieces, I personally believe there's no hope of success. So from that, we were asked to come up with, okay, if we're going to look at identification and prioritization, what would a more specific process look like? So we got together a little focus group and spent 2 consecutive meetings really talking about what would the principles of an identification and prioritization process look like that you would be prepared to get behind. And these were the 5 things that came up. So they wanted it to be data-driven. We wanted to be able to really demonstrate within our own data sources that this was a problem, how big the problem was, and if we were successful in fixing it. We wanted it to be routine and replicable. And in that, there's also parts of, if this is a lot of work to do, we will not do it with any regularity. So it has to be kind of a strong process that is reliable, but is a shoestring kind of process. We don't have a lot of resources. We don't want to spend all of the extra things that we're finding in here on identification and prioritization. Like, this has to be cheap, basically, for lack of a better descriptor. We want it to yield a high return on investment. So, waste, there's all sorts of pockets of waste. Some are bigger than others. And we wanted this process to be able to identify, if we were to target this area, is it worth our effort, and what would the expected returns be? And there are cases that I'm sure as we get more sophisticated in this, we would look at and we'd be like, yes, I recognize that's waste, but it's just not worth us pursuing right now. So, enable stakeholder collaboration, and that harkens back to my earlier comments about it being a required component to have collaboration across the system on this. And actionable. So we wanted things we could actually move forward on. That was a very important component. So from those 5 points, we came up with a process that we've actually tried out. So the first step was to identify technologies. And so we came up with 3 different input sources. And none of this will be particularly surprising to you if you've been in this world for a while. So we thought horizon scanning and new knowledge. So, looking at big RCTs coming out, heavy buzz technologies. If they're coming into our system, we could expect that there would be things we should be doing differently with the technologies we already have. There are many things that don't need to be an add-on to the existing care pathway. They can be a replacement for things we already do. We also wanted to have a stakeholder input mechanism, and this really harkens back to that stakeholder engagement and stakeholder collaboration. And then lastly, a data-driven process that we looked at. And with those first 2, it's relatively well documented that there are a lot of effort for small-ish returns in terms of ideas and technologies. but they're very important to have so that you have a credibility to your process. It's very important, for example, for people to feel that they can suggest a technology if they feel it's important for them to bring forward. So those other two are really important to have, but we recognize that probably the bulk of the technologies we were considering through this process would come up through this data-driven mechanism. So for that data-driven process, we came up with another 5-step process, and we thought, well, we recognize that people have already put a lot of effort into developing other lists of low-value care. So the Choosing Wisely Canada campaign has a list of over 175 technologies. The NICE Do Not Do list is about 900 technologies long. Australia has a similar list combined with their Choosing Wisely and some things that they've recognized as low value that's got over 150 technologies on them. So we thought, why reinvent the wheel, particularly that Choosing Wisely list, where it's been endorsed by professional Canadian medical societies as a list of things that they recognize are low-value care. That kind of gets us over this initial, well, is it or is it not low-value care? A credible source has said it is. And so we thought, let's start from there with this and see where we get to. So we compiled the lists of low-value recommendations that are already out there. The main one being Choosing Wisely Canada. We then coded each recommendation in the appropriate coding system language. So for us, as an example, that would be ICD-10 if we were looking at hospitalizations. And we then worked with Alberta Health analysts to examine the frequencies and attach costs for how often that was happening in the province annually. And then we ranked that list based on annual budgetary impact. And then we proposed that we would share the list for stakeholder collaboration and action. Again, recognizing kind of where we stand in the system makes action the most challenging piece for us. So we did a draft, we got the okay and the buy-in to move forward on this in a draft way just to prove, can you do this and does this actually yield something that would be meaningful to us? So this is a flow chart of kind of how all of those things flow together. So you'll see that when we combined the 3 lists, we came up with over 1,700 unique low-value care recommendations, which just at first blush to someone, that was kind of a lot. I was amazed, actually, that there were 1,700 recommendations out there of low-value care. That's a big number, in my opinion. Of those, we had to exclude a large number off the bat, because in this first draft pass, we were looking for things that my non-clinical head could code in ICD-9 or 10 codes without applying anything that made me nervous. So it was like very, very clear cut. Do not use this technology, for example, in people with this condition. And there was clear ICD codes for both of those things. So this number got very small very fast because we were trying to keep it super clean at this point from like a non-clinical data coding perspective. Of those 54, 31 of them had some kind of budgetary impact within the province. So there was 23 that had 0 frequencies. So that, as a second kind of bullet point, was reassuring that half of the things we could code were not happening in the province, so that's good. And then of those 31, we arbitrarily said we're going to call high budgetary impact greater than $1 million budget outlay within 1 annual year. And there were 14 of those from that 31. And just to give you kind of a look at what this looked like when we shared this back with Committee 10, which is now called the Evidence-Based and Appropriate Care Committee. I think I got that name right. So what we shared back was to say, so this was one of the recommendations, a discectomy for pain in the back. There was 2,450 inpatient dad stays with that. Here's the average cost based on kind of CMGs and IRWs and all of that. And then the cost of the claims associated with that, and then the total estimated annual budget impact on your far right. So to show you, there is a large variation in those estimates. But reassuringly, reassuringly for our process, we were able to identify things that when we took this back to a group of clinicians, they're like, yeah, actually that I buy that. That doesn't really surprise me, which was really good validation for us in terms of it worked. We got things that we could probably use to engage our stakeholders. these are actionable things, they are high budgetary impact, and we could make a meaningful contribution here. So, what are the next steps in that particular process? So as you can imagine, when we took that back to our committee, they were kind of excited about this. And so they said, okay, move beyond the draft now. Like, do this with more rigor, more clinical engagement, more engagement from people within the portfolios. And we'll come up with a broader list that we can then pick from and share more broadly across the community for people to consider if these are things they'd like to action. So what you'll see here is that for the recommendations that are really clinically practiced, clinical practice focused, we're working with the evidence-based and appropriate care committee, the SCNs, and the appropriateness area within AHS to action those items. For the drug recommendations, we're working with the pharmaceutical portfolio. And then for the lab-focused recommendations, we're working with Calgary Laboratory Services as well as Prov Labs and Pathology to action some of those lists. We've just finished our last data analysis, so we're preparing all the lists to share more broadly, and I'm very excited to do that next week. The last thing I wanted to share with you was kind of a different piece of work that we've been working on to guide people when they're thinking about a reassessment. So we've come up with five questions to kind of help you frame your thoughts, because one of the things we heard a lot was, again, harkening back to our stakeholder engagement pieces at the beginning, I don't understand what you're trying to do. I'm really struggling to frame this. We took that back as a research team and thought, well, can we develop questions that you could ask yourself that would help you figure out a way forward? And so this is the little matrix, or some might call it a logic model, that we came up with. And I put this in here and share it with you really because I thought this might be useful for you. So first thing we would ask you to think about is, what is the value of the technology? So are we talking about something that's high value, low value, ineffective, no effect, harmful, or you don't know? And to categorize the technology into one of these boxes, you might have to do a lit review, a systematic review, to figure out where this fits. And then depending on which box you fall into here, your problem is different, right? So once you've figured that out, then you would look at what is the current utilization gap. So if it's high value and it's underused, you're trying to increase the utilization of a particular one. If, for example, it has no effect or it's harmful, it might be overused or it might be misused. So then you're trying to decrease use, and the problem you're trying to solve is different. If you're in this uncertain benefit and harm, you actually might not even know how it's used. And so really along this black box stream, you're talking about knowledge generation as opposed to implementation science and action within the system. Next, we would ask you to think about, well, what are the available tools and resources for you, because that will kind of drive the scope of the action or the implementation plan that you could develop. So if you have strong data you can pull on instead of having to gather data as a primary data gathering tool, you might have more success if there's something in admin data that you could routinely measure and have an analyst crank rather than having to go and do chart reviews every year. Next, thinking about what are your levers for change. And here I didn't talk about this a lot in the presentation yet, but there are a variety of levers available to change practice, and not everybody has access to pull the same ones. So particularly for you, in Alberta Health, you might be thinking, well, we have a policy lever that we can pull. We might have an incentive lever that you can pull in terms of maybe changing the schedule of medical benefits, maybe changing the way money flows, maybe offering grants, maybe offering awards, things like that. But some of these other things might be harder for you to implement. So for example, reminders, it might be harder for you to implement an electronic reminder within the chart of the patient than somebody within AHS at a lower clinical level. And then lastly, you're going to want to think about, well, what is your desired outcome? And again, that will kind of guide you into, well, what would success look like for you here? And throughout all of that, thinking about who are your foundational actors and who do you need to engage to make this successful. In closing, I just wanted to offer you a couple of my reflections that I've learned as I've been working in this field for a while. So one is a rather perhaps obvious, but I'll say it anyways. The intensity of the effort in this space is really amplifying. And I think what that really means for us is that because we're a relatively small community and we're all facing common challenges, coordination and collaboration are the key here. I don't think we all have to learn the same lessons the hard way. So if we can share that and kind of piggyback on each other's knowledge throughout Alberta and then Canada and internationally, I think we'll get a much further than if we all repeat the same successes and failures. Adaptation to the context and the culture is crucial. I hadn't appreciated how important that was when I started in this field. And there are reasons why things take the path they do. So again, if you think back to that timeline, as a young academic in my first year on my faculty appointment, I got asked to develop the provincial strategy for HTR and really couldn't understand why it didn't go anywhere. And I understand now, with the benefit of hindsight, there's lots of reasons why that was paused and lots of reasons why it's come out now as a document that we can refer to. And you in the policy environment would be very aware of that. Timing matters, and there's lots of reasons why things do or do not go the way that you think they will. And being aware of that, I think, helps you really navigate towards success. The last thing is that implementation and change management are key. So we can identify and we can prioritize and we can talk about waste, and we have been doing that in a relatively concentrated way for about 5 years as an academic community. Where we're really struggling is taking that next step, and that's really where we push into implementation and change management. And those are hard things to do. They're very context dependent, and they're possibly resource intense. I mean, supporting people to change can be extremely intense. And so I think being really thoughtful about the things that we choose to pursue is very important. Because, for example, if we know that to support a community to change their practice on a particular prescribing pattern will save us $10,000 as a province, how much do we need to spend to support that community to properly plan through that change? Probably more than that. Maybe that's not where we want to focus. So I do think that this being really thoughtful about where we use our scarce resources for implementation and change management is the key to moving forward and having success here. With that, I will close. I really look forward to your questions and comments.
Okay, thanks very much, Fiona. And I just wanted to say goodbye to those people who are online, and the presentation will be there. One thing I did want to note, there is a forum which the Institute of Health Economics is putting on February 22nd, which Fiona is participating in, actually, but it's along with CADA, the Canadian Agency for Drugs and Technology and Health, and a bunch of other partners, called Doing the Right Thing Right. And actually a lot of it is going to be focused on dealing with clinical decision-making and how evidence products are actually uptake in the physician community, and include the TOPS program towards optimized practice in the AMA, the strategic clinical networks and others, because there is a kind of a lot of work going on internationally and other places where we produce evidence and we present it out and we're all frustrated. Well, why do all these people keep on doing PSA tests if they're not necessary? Or why do they do that? And there's lots of interesting reasons as to how one sets up structures to make that possible. So that actually that'll be a forum which will be taking place with the support of a bunch of partners. But please, goodbye to everyone online, and then we'll be having a question and answer period in the room.